Hi, I'm Dr. Jane Burns, and I am the director of the Kawasaki Disease Research Center at the University of California, San Diego, and Rady Children's Hospital here in San Diego. I think there's a common misconception among physicians who are not very familiar with infliximab that there's a great concern about immunosuppression, about reactivation of TB, histocoxy, and all of the chronic complications that are connected to infliximab use when it is used chronically. And I think it's very important to be aware that families are going to go online and look for information about infliximab, and they need to be told up front that a single dose of infliximab has not been associated with any kind of reactivation of any of the chronic pulmonary diseases, nor is it considered immunosuppressive as a single dose. And that's very different than what they're going to see online. So there needs to be that guidance for them. And I would recommend doing that in the conversation that you have about introducing it. As far as your knowledge base as the physician, there are obviously 3 commonly used treatments for IVIG resistance as defined by the American Heart Association. And those treatments are corticosteroids, infliximab, and a second IVIG infusion. I would really urge you to read the KidCare study that was published in Lancet Child Health, because it does a direct comparison between infliximab and second IVIG. A head-to-head comparison between steroids and infliximab has never been done. So we can't help you with data there. And I think it's really center preference and comfort level. Here's what I think you need to explain to the parents. If the choice should be between steroids and infliximab, because really I think the KidCare study takes second IVIG basically off the table. I mean, in the KidCare study, infliximab versus a second IVIG, infliximab resolved fever faster. There was less requirement for additional medications. The CRP dropped faster, and patients were in the hospital for a shorter period of time. So I think all of those are winners. And then there's been a subsequent study that was done looking at cost effectiveness. And as you can imagine, both from a strict cost perspective as well as from a nursing perspective, a 2-hour infusion of infliximab is really better than a 12-hour or 10-hour infusion of a second IVIG, and the cost is clearly less. So if you're thinking or presenting to the family steroids versus a second IVIG, what you're presenting is a 2-hour infusion in the hospital for the infliximab. No need for ramping, no need for any kind of TB testing or quantiferon, anything like that beforehand, no risk of infection, and no documented reactions to infliximab in the Kawasaki disease population when used for this single infusion. So that's the story for infliximab. For steroids, it's very safe medication that has been used for years and years and years, but has side effects. And those side effects are well known to all physicians, but include increased appetite, behavior disturbances, trouble sleeping. And it's an oral medication that is recommended to be given in split doses, so morning and evening. And in a toddler with a not very good tasting oral medication, that's a challenge and a burden for the family. And it's a medication that is ideally used with a taper. So we're talking oral medication for maybe 2 weeks, including the taper to come off. So those are the trade-offs. At our center, where we use infliximab at a dose of 10 milligrams per kilo for a single dose, we've had no complications, and that's documented in 2 rigorous clinical trials, both KidCare, and then in 2014, there was another trial published in The Lancet with Audrey Tremblay as the lead author that randomized basically 100 kids to get infliximab with no adverse events at all. And this was a multi-center trial, so not just at our center, but across diverse different hospital settings. So that would be the straightforward way of presenting it to the patient. IV medication given intravenously. All of these kids are still in the hospital and they have an IV, so that's easy, versus going home with an oral medication spread over 2 weeks. I think that what they really need to do is read the KidCare study, and they will have the information that they need to make an independent decision. I don't think it requires subspecialty consultation. Rheumatologists and GI docs who use infliximab chronically have a lot of concerns about infliximab just because their experience is with it as a chronic medication given over years. And that whole set of concerns has nothing to do with use as a single dose in the setting of Kawasaki disease with recurrent fever. So I would suggest reading the medical literature that's relevant, which would be the KidCare study, and then forming an opinion. It is absolutely not indicated and not reasonable medical practice to have any concerns about TB testing before initiating infliximab or any other kind of evaluation of the patient. This is a very, very safe and straightforward medication. And I think reading the literature is really what's required here, not subspecialty consultation. The number one reservation, I think, has to do with immunosuppression, which is a reasonable concern for chronic administration and an irrelevant concern in the setting of a single dose with IVIG. We carefully consulted the big pharma company that at the time was making infliximab about their post-marketing surveillance for any kind of reaction, infection, problem following the first dose of infliximab, and in patients who were not otherwise immunocompromised, like not rheumatologic patients on DMARDs or other situations like that, but with someone who is immunocompetent, a first administration of infliximab was never, in their post-marketing surveillance of many decades, had never been associated with a reaction. So I think it's safe in this patient population for this indication in this setting, but there is a lot of hesitation among physicians who are not accustomed to using it. And when they consult their colleagues in infectious disease, who are the doctors who have to deal with the terrible infectious disease complications in kids on chronic therapy, there's a lot of hesitation. And when they consult with their rheumatology or GI colleagues, similarly, their experience is all with chronic administration, and it's just a different beast when you're dealing with a single infusion.